Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, AAOMPT listeners. Antigone Vesci here, and I'm excited to introduce our next guest on the podcast, Dr. Jesse Anderson. Today, we will be discussing his poster titled Physical Therapist Management of Temporomandibular Disorder Following Buccal Mucosal Urethroplasty, a case report, which recently won first place at our annual conference. I had the pleasure of hearing him deliver this poster right before the judges and was excited when he won this award to bring him onto the podcast. But first, let me tell you a little bit about him. Dr. Anderson earned his Doctor of Physical Therapy degree from Northwestern University and completed his orthopedic residency training at The Ohio State University. He most recently finished the Northwestern University Fellowship in Advanced Orthopedic Physical Therapy Practice, Research, and Education. He is a board-certified orthopedic clinical specialist and, of course, a fellow of AAOMPT. He is currently practicing at University of Illinois Health in Chicago, Illinois. Dr. Anderson, congratulations on the success of this poster, and thank you again for coming on this podcast.
Thank you for having me. Very much happy to be here.
I really appreciate your time. I think that this is something that is really novel and interesting, which is why it got recognized at AAOMPT. And I think our audience is really going to get a lot out of this. So without further ado, I thought we would start by having you define what a buccal mucosal urethroplasty exactly is and which patients are getting this procedure.
Yeah, I think that's a great place to start. I certainly was not familiar with this procedure at the time of evaluating the patient. However, it's fairly common. So if we break down the language, a buccal mucosal urethroplasty, which is sometimes referred to as a urethral reconstruction with a buccal graft, is certainly a mouthful to say, but a urethral reconstruction is done, or a urethroplasty is done, for cases of urethral stricture. So it's fairly common for men in the middle and older ages to start having issues with a collapsing urethra, essentially. And while it may exist on a spectrum, the eventual gold standard treatment for more disabling cases is a urethroplasty. So what they do is they harvest a graft, in this case from the buccal mucosa, and they work to actually rebuild or reconstruct the male urethra. They had in the past used other graft sites, but those were associated with things like infection and other post-surgical risk. So the buccal mucosal graft is now considered the gold standard. As we'll talk about, there's not a lot of complications post-operatively after the initial recovery, and it tends to have histological properties that make for a better graft site, apparently. I'm not a urologist, but that is just what I read.
So where exactly is the buccal mucosa?
If you right now kind of press your tongue on the inside of your cheek, that mucosal tissue on the inside of your cheek is the buccal mucosa.
Very cool. So this procedure seems to be more common than we might realize. It tends to go off pretty smoothly, but why was this patient specifically coming to you for treatment?
Yeah, that was my first question, was how prevalent really is this? Is this a common complication? Because as we'll talk about, the patient ended up having 2 years of chronic disabling jaw pain. So the literature is pretty vague on this. The existing research in this area doesn't necessarily answer the question probably as sensitively as we'd like as physical therapists. The questionnaires that are commonly used aren't validated to detect things like temporomandibular disorders. You know, they ask questions in research on, hey, do you have any oral numbness, or do you have any impairments or problems with eating? And it's usually given on a Likert scale. But overall, we don't exactly know. However, there are reports of people subjectively saying they have chronic limitations in mouth opening. Understandably, you'd have some limitations in the first couple months as you're recovering. But even when they follow people out at 6 months or 9 months, there was a substantial piece of the populations that they examined that did report some limitations in mouth opening, which can be a component of temporomandibular problems.
Definitely. I treat the jaw a lot, and jaw proprioception is something that's always been interesting to me. because when they ask patients, do you have a limitation in mouth opening? I've seen patients who feel like they do, and then you measure it and they really don't, or maybe they're even excessive. So I think that question is just interesting, definitely very subjective, but could definitely be a contributing factor to jaw pain. Can you please tell us some more about this case? Who was this patient and what brought him to you?
Yeah, so he was a 64-year-old male, and he was actually 2 years post buccal mucosal urethroplasty. And the story that he had told was he had this procedure for urethral stricture, and everything seemed standard and going to plan. And he said that part of his recovery went just fine. However, up in the jaw and in the face, he ended up developing kind of a gradually worsening pain from essentially the pre-auricular area in front of the ear that radiated down the mandible all the way to the chin, essentially. So his primary concerns on the evaluation were, of course, the pain that he was dealing with. It had been 2 years, and he even said at that point it was kind of gradually worsening. And he had typical problems that you would expect with patients with temporomandibular problems. So he had a hard time opening his mouth wide. He was really restricted in his eating habits. So he described, cutting foods into tiny little bites to avoid significant pain flare-ups. He wasn't able to eat chewy or hard foods due to the pain. Eating a sandwich or bread was totally out of the question. And he was also understandably a bit apprehensive about certain things. Like the topic of trying to bite into an apple came up, and he said he would never try that. He was apprehensive about episodes of locking. He didn't describe any true locking, but he described, a sharp pain if he were to try those things, and he was fearful that his jaw may lock at some point. So he did have what looked like pretty typical complaints like that on paper. But when something that was really unique was he kept talking about how he would frequently bite the inner cheek. He would accidentally bite his right side of his buccal mucosa where the graft was taken, he said, nearly every day. And it would be a sharp pain, and it would kind of shut him down for a few minutes, and he would have to let things calm down. And that was one of the more unique parts of this case.
Was that pain locally on his inner cheek, or did that reproduce his primary pain of his ear and jaw pain?
That's a really good question. In his case, he didn't really define these two areas as two different pain areas. So they're all one kind of continuous location of pain. However, when he described it, it sounded like it was just a really sharp intraoral pain, but it would cause a lot more extraoral pain, I guess, if you can call it that. But he would have a lot more of his typical kind of radiating mandibular pain.
That's really interesting. And being 2 years out, could you observe anything on visual exam, any changes into that soft tissue, or did you perceive this to be a central sensitization response?
Definitely both. So kind of an and not or situation. I think the question of like soft tissue mobility is always hard to define. I don't think there's a good standard scale we can use, especially of the oral mucosa, which I don't pull on, and I don't really find many limitations in on a typical patient. There was some hypertrophic like scarring over his graft site. It was a bit raised and it just felt stiff. Like if you were pulling on your inner cheek right now, it just felt like it didn't have as much play in it. It was really just stiff.
Interesting. What other objective findings did you find on this patient?
Yeah, so I think the relevant things to highlight were first and foremost a negative cervical exam. So I had expected to find something in the cervical spine. I think that we're not doing a jaw evaluation any justice if we ignore a full examination of the cervical spine, especially the upper cervical spine, as that can be a powerful source of symptom referral into the craniofacial region. The examination there, however, was pretty unremarkable. On one hand, it seems surprising that he didn't have any findings in his cervical spine, given how long this pain had gone on. On the other hand, it wasn't surprising because during the subjective exam, there wasn't really anything to indicate that there was a pain referred from the cervical spine, given that all the aggravating factors seemed to be like related to his oral function and chewing and biting and talking, things like that. His pain was most closely reproduced with palpation of the masseter, both extraorally and intraorally. But the surrounding musculature, so like the lateral pterygoid and even the suprahyoid region, was all pretty tender. So notable hyperalgesia in these areas, even with very light somatic pressure, was causing a sharp pain. So the whole region seemed a bit sensitized. more than what I would just expect if it was a local nociceptive problem. With accessory exam within the jaw, he did have a unilateral hypomobility, both with an anterior glide and a caudal glide. And that definitely came into play and was pretty clear when he would move his mouth. So when he would open to his maximal range, he would deflect a bit towards that side, as you'd expect with a unilateral hypomobility. And same thing with protrusion. He would drift away from the midline and towards that stiff side. However, most joint testing was negative for pain. It was just a report of stiffness. So despite some of those other findings, the most familiar pain seemed to be with palpation of the masseter, and that even reproduced some referred pain. So the closest diagnosis we could assign to this case was myofascial pain with referral involving the masseter muscle. However, I do want to note that there was that secondary regional hyperalgesia in that ipsilateral musculature and a little bit of pain within the joint too, despite it not being his familiar pain.
So this may be more like a chicken or the egg thing, but did you believe that the range of motion was restricted because of the pain with the chronicity of this case? Or did you believe the range of motion was causing the pain in those muscles?
Yeah, I'm glad you brought up the chicken and the egg, because I think that's relevant with pretty much every patient. I think for him, it was a little bit of both. If I had to put it on a scale, I would definitely say that pain was the primary driver of his limitations rather than the limitations and impairments being a driver of the pain. So I guess that'd be the chicken in this scenario. I think the history of the condition can be an important factor. For him, just the story that he told with that gradually developing pain and his post-op recovery not necessarily going as planned, his story really seemed centered around a gradually worsening pain-limited jaw and oral function. And I think this was confirmed later during treatment as his symptoms would rapidly improve with things like manual therapy and exercise. And many of those limitations that you can try to measure with your physical exam did improve quicker than what I would expect if it was just due to some local biomechanical impairment. Of course, those impairments like that TMJ hypomobility were definitely influencing his presentation, and that came into play later on. They were much less of a factor when compared to that pain that he was having.
Yeah, so since you touched on treatment, what exactly did you do for this patient and what happened?
Yeah, so I did what actually seemed like fairly routine temporomandibular joint care. So it was a combination of manual therapy and reinforcing exercises. And I had only seen him for 3 follow-up visits during the course of care, despite having 2 years of jaw pain. Initially, I would say the first couple of visits were all focused on pain modulation. And initially, those things were focused on trying to desensitize the surrounding tissue. So things like scar mobilization, which surprisingly he had not been instructed to do postoperatively. Just mobilizing and stretching or desensitizing that scar was one of the first things that we tried, and he could easily reproduce that himself. And then from a more traditional standpoint, did some intraoral soft tissue mobilization to the masseter. So kind of went straight for that bullseye of his pain presentation and actually worked into a bit of pain. Tried to apply a mildly noxious stimulus to see what response he would have. And he had an immediate improvement in his maximal mouth opening and pain. So having him follow that up with self soft tissue mobilization was easy enough. That was then kind of blended as the pain improved to focus a little bit more on some of those contributing impairments.
Given the irritability that you alluded to earlier, what made you choose to push into a more noxious stimulus?
I think I didn't have any evidence to support that I needed to avoid a noxious stimulus. So we know that noxious manual therapy can have some benefits in many cases. Manual therapy does not always have to be painful, of course, but it also doesn't always have to be comfortable. I think your functional reassessments before and after your treatment are going to be kind of your North Star. So given that we had trialed some noxious soft tissue while monitoring for his symptom improvement, it was pretty quick that tenderness that he experienced calmed down within probably the first minute of applying it. So when I'm utilizing a technique like this, I'm always going to be monitoring for symptom change within the application of it. As I'm checking in with him, he's telling me that the pain is actually decreasing and it felt like a good pain or a good pressure. I felt pretty confident that we would see a good response. And then shortly after, with his opening being wider and his mouth being less painful and him reporting less apprehension with that in-range position, I could feel even more confident.
I agree with you. I mean, 2 years out, there's likely no inflammatory process anymore in play unless he's creating that by continuously biting the area potentially. But that immediate effect is definitely encouraging to desensitize it, and potentially just some pain science education a lot sooner might have really helped this patient out. He may have been avoiding pain, contributing to those impairments over time, which is why he noticed worsening of those symptoms.
Yeah, I think that's a really good point. I think thinking about tissue healing timeframes, of course, if he had this procedure done 3 weeks before, pushing into pain during an acute inflammatory process wouldn't be the smartest move. So I'd never advocate for that. In his case, yeah, it had been 2 years and there wasn't really much tissue healing to occur from a physiologic level. It was just a sensitized area.
So that was the first visit. And then what else did you do?
Yeah, so his pain actually improved quite a bit from visit 1 to 2 to 3, and the biggest problem, as we talked about, was the pain. And I think as you modulate the pain, you'll find that many impairments just disappear. It's oftentimes, again, I guess, the egg, if we're talking about that chicken and egg. The focus shifted from some of that pain modulation stuff, some of that noxious soft tissue, towards managing contributing factors. And one of the biggest things was whether it be due to nociplastic changes over time or just limitations in mouth use over time, or due to secondary hyperalgesia. He had some significant stiffness on that right temporomandibular joint when compared to the left. So there was a lot of joint mobilization that I thought he would benefit from. And similar to what we'd done before, there's almost always some type of reinforcing exercise that if we can apply it, we will. So we did some mobilization with movement into opening, actually applying a little pressure to the ramus of the mandible as he would open, and then had him kind of apply that same technique to himself. And again, always monitoring for within session change. And, within just 5 to 10 minutes of each dose of treatment, he seemed to get a little bit further with his opening and a little bit more comfortable. And then by visit 2 and 3, it was virtually no pain at this point, and it was just a bit of stiffness on the side of his jaw and some objective limitations in opening. I guess to highlight the level of limitation, he initially had about 30 millimeters of maximal mouth opening, and by the end of care, he had 41 millimeters. It's not the worst I've ever seen, but it's not fantastic. So there was some definite restrictions in maximal mouth opening that needed to be addressed. We continued to address that contributing factor, which seemed to be the joint hypomobility on that right side, both with manual therapy and with exercise, both for mobility and kind of motor control working into those newfound ranges. But standard techniques, things that we've probably all practiced at some point, like your typical anterior glide and your caudal glide, which followed the presentation on that visit with what was most limited on a manual assessment, really did drive my decision making and was helpful both within session and between.
You alluded to him having some fear avoidance of mouth opening tasks like eating an apple earlier. Did him experiencing less pain directly improve his willingness to try those tasks, or did you have to encourage that in any sort of way?
I actually love that you asked this question because I am thinking back to when I saw this patient, and it was actually during my fellowship year, and I was with a mentor of mine at the time. And, I'd kind of been talking about the case and where he was and how things were going. And, I'd kind of talked about this fear avoidance component, and, the guy was really self-limiting with cutting his food into tiny little bites and really doing everything he can, eating softer foods, trying to do everything to avoid pain at all costs. And what's funny is I came up with like an action plan. I was like, look, we're going to come in there and I'm going to talk about graded exposure to eating and chewing and all the things that he's apprehensive about, with the peak of that mountain, the summit being taking a bite of a big fat apple. However, it was funny because he came back for like that, I guess that second follow-up visit, and he was like, I'm feeling great. And I'm like, okay, talk to me about eating. And he's like, I had a steak. It was fine. It's no problem. It felt great. And I was kind of pleasantly surprised I didn't need to go there. So I think the lesson that I learned from this, which again applies to many patients, not just jaw patients, is if you can adequately assess and treat that pain, many of those secondary limitations might just go right out the window. Of course, there's a time and a place where there may be some pathological fear avoidance that you have to address with graded exposure or graded activity. But in this case, actually, you treat the nociceptive driver and he was feeling fine. He ate whatever.
I love that. I love that he's like, I'm just going to load this joint and test it out.
Yeah, it's funny because on the evaluation, we know how important expectations can be. And on evaluation, he didn't really know what the heck he was doing in our office. He was like, what can you do for me type of thing. He didn't expect it to help. And obviously, he quickly changed his tune because he's like, I didn't think this was going to work at all. You know, I remember on that second or third visit, him talking about that. And I was happy he was pleasantly surprised.
That's great. I think you making such a notable change in such a short time, changing those expectations was very motivating for this patient. It's clear. Is there anything else about this case that you'd like to share with us from your research or from your interactions with this patient?
Yeah, I think we covered the big picture items. I think when you look at the case, it seems really novel, of course, because it's not a very well documented management plan with this population. We don't necessarily have to treat even this novel presentation as anything too unique. I think the same old mantras of calming things down and building things up is still what we do best as physical therapists. We understand pain neurophysiology really well. And if we can apply that in combination with some of the kinesiology and biomechanics that we learn at our foundation, I think we have a really good opportunity to help many patients with persistent pain. So we know that the practice patterns for temporomandibular disorders doesn't always facilitate early rehab management. However, hopefully as we continue to treat these conditions, we see more and more of these cases in the future.
I have one last question. Did this patient ever go back and see their urologist and report this pain? Because one area that I'm thinking as you talk through this is just how your case could potentially reach a whole new referral source for physical therapists and how we could have prevented this chronic pain in this patient's case.
Yeah, so as you might expect, if you're a urologist, you may not be super comfortable managing chronic oral pain. So he did end up getting referrals to, multiple providers. I believe he saw an orthopedic provider. He saw a dental pain specialist who referred the patient over to our clinic. I believe he did also have a pain medicine referral at some point. However, I think you and I would both know and appreciate that an earlier presentation could have been really helpful in his case. He probably didn't need to see that many people given how quickly he improved. So as far as I'm concerned, he reported this to his urologist, but after that immediate postoperative period, I don't think it was really within their area of expertise. So he did end up getting referred on, and of course, luckily, he got referred on to a physical therapist.
What would you love to see come out of this case?
There's very limited data out there. I think that we still don't know enough about how prevalent this problem really is postoperatively. We're still in the early days of recognizing the potential need for PT intervention for this population. We don't even really know how many patients develop TMD after this procedure. So further research kind of clarifying this could be helpful. And given how there do seem to be some temporary limitations for most patients, I wouldn't be surprised if there may be some really simple interventions, things like self-massage of that initial scar, that initial tissue injury. It would be interesting to see if that would make a meaningful difference in larger subsets of patients. I'm sure there are plenty of patients, like the evidence suggests, that do just fine. But there may be a small subset of the population where those small little things can actually make a big long-term difference in preventing a longstanding issue and chronic disabling pain like it did for this patient.
I couldn't agree more. I think it would be really interesting to see what a simple patient education handout for patients like this could do. But like you mentioned, it's not really clear how common this problem is. But I think that's an area we as physical therapists could really step up with other healthcare professionals to try to prevent things before they get to this point.
I couldn't agree more. I think even when I saw this patient as I described, I had no idea what I was talking about or what this procedure was. I needed to do a bit of searching myself, but I do feel confident that I know a couple things about pain and I know a couple things about the jaw. So I think he ended up in the right hands.
Well, Jesse, thank you so much for taking the time to present this poster, to be on this podcast. This is going to get out and people are going to learn more about what this is. And so that when they see a patient like this, they might not have to do as much homework as you did. I hope that this inspires some of our listeners to look more into this or to maybe even follow it up with a study to help you get some more clarifying information on the incidence and prevalence and things like that.
This was really fun. I appreciate you having me on, and I've always been a fan of the AAOM podcast, and I was humbled to be asked to be on, so I really appreciate you taking the time.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AAOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AAOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.